Welcome to Gutsy Talks. I'm Rachel Larson, your host, naturopath and nutritionist, and I'm here to have real, honest conversations that can help you heal your gut, calm your mind, and fall back in love with food. Together with leading health experts, we'll dive into all things gut health and explore the deep connections between your gut and overall well-being, so you can feel empowered to take control of your health and live your best life. If you love all things gut health, follow me for more on Instagram at rachel.larson or head to rachellarson.com.au. Now, let's get into today's episode. Today's guest is Tara Nelson, a powerhouse in the world of thyroid health. A naturopath with over 30 years of clinical experience, Tara is a leading voice in thyroid education and practitioner support. She's a sought-after speaker across health podcasts and professional organisations with a clear mission to raise awareness and provide vital education around the importance of thyroid function in the body. Tara is dedicated to empowering both individuals and practitioners in navigating complex thyroid conditions, and she leads renowned training programs and a mentoring membership, equipping practitioners with the confidence and expertise to excel in thyroid care. So we're delighted to have Tara here today. Welcome.
Thanks for having me. I'm excited.
I'm so excited too. You really are the person that our industry thinks of when it comes to integrative and holistic thyroid care. And as much as I guess we're all aware of thyroid health issues, we really aren't in terms of what we need to know to really support patients properly, get a proper diagnosis, and I guess do what we can in a way where people don't feel like they're at the mercy of a bad thyroid, whatever that means for them. So I really wanted to get you on here because there's so much that people need to know that I know they don't know from many clinical conversations I'm sure you and I have with our patients.
Yes, definitely.
So tell the people who aren't aware of you, tell us how you got into this field of thyroid conditions, thyroid health.
Yeah, well, for a couple of reasons, I guess. So I guess professionally, I'd been a practicing naturopath for 20 years, and I was kind of coming to a point of like, what's next? I've been seeing face-to-face patients, and I'm going to say that I had a great little practice, very busy, been in the same town for many years. So I had great, like doctors, GP referrals, other allied health professionals. So it was great. But I was sort of thinking, what's next for me? And, when you always start asking that question, I'm a big believer in what you put out into the universe, something will come back. And I guess what I started to see in clinic from that point on was so many thyroid conditions. And I really, before then, like 20 years, I can't say that I saw a lot. I wasn't on my radar, and we didn't look a lot at pathology testing, I guess, in the early stages back in, the late 90s when I started practicing. Yeah. So, I was presented with all these thyroid conditions in clinic, and when I was looking at my protocols that I had on hand, when I was looking at what my textbook said to me, the patients weren't matching up with the symptoms or the presentations. Like they would have, someone would present with perhaps very hypo symptoms, but would have hyperpathology results or opposite. And I just started to see, am I getting these really complex thyroid presentations, or is this just the norm? So I felt that what I had been taught many years ago, 20, 30 years ago, was just not enough. So I started really throwing myself into research and applying those principles that I was learning to my patients, and started getting really good results. But I also went, wow, if I don't know this, and I've been practicing that for 20 years, what about the other practitioners out there? And then along the way, so I started really sort of specializing in it, and really sort of putting my name out there as like, yeah, come and see me, because I'm starting to really look into it. Along that journey, though, interestingly, I discovered my own thyroid condition, and which I believe was not diagnosed. I think I had 3 children in 4 years very quickly. I had 3 cesarean births because I couldn't birth my children and my babies, and busy time. And I think I had the perfect storm. My hair all actually fell out, snapped off, but I didn't put 2 and 2 together. And I was a naturopath. I mean, I had 3 small kids in 4 years. Like I was busy, it was crazy busy, as mums are. Mums are busy. Mums are tired. We do suffer postpartum hair loss, all of the things, right? But when I got my diagnosis, I was gobsmacked. My GP actually rang me and said, oh, do you know that you've got a TSH of like 7.39? I've gone, what? And I
Mhm.
had very low thyroid hormones. And then we tested the antibodies, and I had Hashimoto's. And I was practicing in this space. I was specializing in this space, and I
Wow.
did not even pick up my own thyroid condition.
Wow.
So after getting over that, after picking myself off the floor and feeling
Yes.
like a fraud,
Yep.
I thought, well, if this is me, there's going to be so many other women out there with an undiagnosed thyroid condition. So it just drove me even further. And then I got to experiment on my own body. And the youngest of my three children, we diagnosed her with Hashimoto's as well. The
Yeah.
other two
Yeah.
are fine, but she has Hashimoto's. And it makes total sense what my pregnancy was like with that third. There's so many reasons when I know it now, why that was genetics and, all of the things. But so yeah, for both personal and professional reasons, I'm now here in this space. It evolves every day. I'm constantly
Yes.
learning all the time. And I love that I get to teach what I learn to both patients and practitioners alike.
Oh, and we clearly need it. Like, like you said, there is just this archaic kind of way of looking at thyroid health, and it's so much more complex. And I think I totally understand that sense of how did I not pick it up in myself? But I think you've highlighted that it can be put down to so many other reasons. Like, that postpartum thyroid dysfunction is certainly something that people go through. Or and even just in day to day, I'm just
Mm.
stressed. I just have enough sleep. It's just my low iron. Like these are symptoms that we could just everybody could find another reason other than thyroid. And especially when we get into the testing process of this, it's no wonder why some of these conditions can go undiagnosed for far too long.
Well, that's the other reason I was having. I mean, of course, I wasn't having a lot of blood tests. I was busy also, but I do remember before that one, maybe a few years prior, I can't actually recall how many years before I got
Yeah.
my diagnosis, is that I did have a TSH of, I remember it being 3 point something at one stage. I remember it being 4 point something, but I was in the normal range.
Yeah.
No GP was flagging me to say, oh, hey, you've got I know now what that is. That's a subclinical
Yeah.
hypo presentation. And also too, yeah, we'll look at the testing in a moment too, but there was no other thyroid test performed.
Yeah.
And that's what I really want to bring awareness around too, is that we cannot rely on a diagnosis from TSH, even though mine was clearly high and
Yeah.
it wasn't picked up, which happens all the time too. It's not flagged, and if things aren't in red on blood tests, they're not flagged, unfortunately, unless you've got if someone that's got the time to actually look deeper. Um,
Mm.
yeah, so I think that's a whole part of this issue, is it's not picked up in the medical profession either.
Absolutely. And like I've got a ton of questions about the testing process because this is also what I see clinically as like, I guess, a frustration. And fortunately, there are, I guess, private ways that we can test now if we're not getting that care. But yeah, it's one of the biggest blocks that people have. So I guess before we get into, well, how do we test for a condition, can we please talk about what is the thyroid? Because we talk about these symptoms and, how is it related to hair loss and energy and those types of things? And what type of conditions can we have with the thyroid?
Sure. Well, the thyroid is a very small little butterfly-shaped gland it literally looks like a little butterfly. It sits right in sort of your neck and sort of below the Adam's apple. And it basically is a very homeostatic little gland, has a really, really important job in the body. So it makes these thyroid hormones, and those thyroid hormones are needed. Well, one hormone in particular makes a couple of thyroid hormones, but one in particular, the active T3, is actually needed in every single cell in your body. So it doesn't matter if
Mm.
that's a skin cell, a hair cell, a heart cell, a kidney cell, a liver cell, a gut cell. It's
All the
every
cells.
single cell in the body needs T3, the active thyroid hormone, to control its metabolic rate. So it's
Mm.
energy. It gives our cells energy. It basically provides the ATP or energy to make all of our cells function well. So you can see so energy production, metabolism, heart contractibility, heart function, kidney function, liver function, temperature control,
Yeah.
some really big ticket items. So we really can't live without adequate thyroid hormones.
Yeah.
So when the thyroid hormones are either low or high, we can start to see, quite a few issues in the body.
Yeah. Wow.
Yeah.
I mean, there's widespread connections and like we're going to get into more ways that it's connected to the gut, but you can see why someone can present with dry skin, they could present with heart palpitation, they could present with a completely different picture to
Mm.
the person sitting beside them have the same condition or on the opposite side of, I guess, the high or low functioning thyroid. Like this
Yeah.
is where we're talking about because it does get told it's like the master of hormones. And it gets these big,
It is.
I guess, labels around it. And that's why it makes perfect sense. So,
That's right.
from a condition perspective, when we are talking about low or high thyroids, like what would be the states of the thyroid health that like what are we looking at when someone's getting a diagnosis? What are we looking for in terms of what's it named?
Yeah. Okay. So there's many, and I think the most common ones are hypothyroidism or low thyroid hormones in the body, and Hashimoto's. And Hashimoto's is the autoimmune hypothyroidism, but they are literally two separate conditions.
Mm.
The next common one is hyperthyroidism, which is too much thyroid hormone in your body. And it's autoimmune condition, Graves' disease. Okay,
Yeah.
so Hashimoto's is the number one driver, the biggest cause of hypothyroidism, and Graves' disease is also the number one driver of hyperthyroidism. But we can go into that a little bit later.
I think that's important to actually like what you said, they're different conditions because
Yeah.
you've probably had it and I definitely have it. People have said, I've got low thyroid function or my thyroid's not working well. And I'm like, but what are we working with? Because they do require different treatment and support protocols. So yeah, everyone
Absolutely.
just like write that down, remember that one. Um,
Yes.
I cut you off. So what were you going to say in terms of
Yeah.
what else can you tell us?
Yeah, so there are most common ones,
Yeah.
in the literature, but we can also, so I see, so I specialize in thyroid health. I see
Mm,
all manner of thyroid conditions. Now, before we get to a primary hypo or a primary hyper, we can have subclinical. And I
mm,
believe this is the most common. This is what I had before I was diagnosed with a primary hypothyroidism. So subclinical hypothyroidism is where
mhm,
we start to see TSH start to rise, but we've got sort of fairly normal thyroid hormones, no antibodies, and we start to see symptoms. So at the subclinical level, so that TSH might be above, like say 2.5, anywhere from 2.5. In the medical literature, a subclinical hypo is actually a TSH up to 10. But I
mm.
would say probably, TSH around 2.5, 2 to 2.5, up to about sort of 8
Yeah.
can be a subclinical. Our thyroid hormones T4, T3 can be fairly normal, no antibodies, but their symptoms. And in hyperthyroidism, it's the same. We start to see TSH drop,
Yeah.
and thyroid hormones are fairly normal, no antibodies, but we might see hyperthyroid symptoms. And we call these subclinical movement at the station. So it's not a thyroid condition as yet, but something is causing the thyroid to act this way.
Yeah.
So that gives us a little clue when we're dealing with a subclinical. What's driving that? What are those causes driving that? And we can capture at that subclinical level. It's so important. I'm really passionate about this. We can prevent it moving to a primary condition, and then maybe save someone going on medication. If we look
Mhm.
at what's going on, what is the thyroid reacting to? Is there been a period of stress? Is there poor gut health? Is it a postpartum? Is it pregnancy? There's so many things that can drive that thyroid to sort of start to fluctuate and go out of whack. So we've got our subclinical presentations, we've got our primary thyroid presentations. I also see cases of thyroid nodules in clinic,
Yep.
which thyroid nodules are really common. They can be, most of them benign, probably about 90 to 95% are benign. But we can also see some of those nodules being cancerous or turning malignant. So I see cases of thyroid cancer in my clinic. We will
Mm.
have all different types of thyroid cancers, from papillary, follicular, medullary, Hürthle. So there's all different types of thyroid cancers.
Yep.
We can see the thyroid having flares. So if you've got Hashimoto's or even Graves' disease, we can see, and you're in remission. If you have a virus or even postpartum, we can see something like postpartum thyroiditis, or even a virus can cause a thyroiditis, a thyroiditis in the body. So there's kind of flares. And if you have high antibodies or even antibodies, you can have these sort of thyroiditis flares from time to time.
Yeah.
We can have cases of congenital hypothyroidism. So people that are born, like babies born with no thyroid in their body. I've got
Wow.
seeing a few patients at the moment, one baby or two babies that have been born without a thyroid, just diagnosed, and then a patient, about a 27-year-old woman that's come to see me, and she was born without a thyroid as well. So
Wow.
congenital hypothyroidism.
And so like would that be, I mean, I'm fascinated by that. Is that something that, I mean, when you said about the 27-year-old or the late 20s, how did they not pick it up before?
Well, she's always known, but she's
She's
come to
always known. Yeah, right. Okay.
So some people come to me at all stages of their thyroid
Yes. Yep.
journey.
Yep.
It could be newly diagnosed, it might not be diagnosed.
Yep.
help them with that diagnosis, or they come in just because they've been struggling for years and they go, right, I just need someone to help me. I've been doing this for years. Medication, I think a lot of people when they're diagnosed are put onto the most common, we can talk about medications, the most common type of medication, but that medication helps the struggling thyroid or in hyper blocks the thyroid hormones, but it doesn't treat the drivers, the triggers of why they got that thyroid condition in the first place. It doesn't decrease or work on the autoimmune aspect if it's an autoimmune condition. So many people have been on thyroid medication for many years and they've just been struggling and they just get to a point that goes, right, I need help. And, they might come into my office or see someone else. We can have something called cellular hypothyroidism, and that is what we call resistant at the cellular level to get their thyroid hormones in. So these are the sort of patients that come to me that look like they've got every hypo symptom, and I would put money when I send them off to their pathology to have their thyroid tested, but they come back and their thyroid function is absolutely fine, but they have very weak or very, very fatigued cells. And so to get that active T3 into your cell, the receptors require energy. So the cells have to be healthy. So people can have very sluggish cells due to many different other health conditions in the body, and they just can't get T3 into their cell. So we call that cellular hypothyroidism. We can have central hypothyroidism, and that is related to something going on in the hypothalamus or pituitary gland. And I also deal with patients that have had either partial or total thyroidectomy. So they've had half of their thyroid removed, or maybe the isthmus, or they've had a total thyroidectomy, and they're coming to me to help with thyroid hormone metabolism in their body.
Wow.
So
Okay.
Lots of different types of thyroid presentations.
Yeah, there's not just my thyroid's a bit low or high. It is clearly
No,
complex. And, if that is the take
absolutely.
home for today, people need to know that when they're exploring their thyroid health, that there is actually the list that Tara just mentioned, differentials that, need to be ruled in or ruled out and
That's
explored.
right. And
And
that's why it's so important to do the right testing. I sort of call it like looking at that thyroid. I call it a thyroid puzzle. It's basically, I look at it as like a puzzle piece, a puzzle. And we've got to have the pathology. We've got to have the testing. We've got to have your family history. We've got to have what you're eating, what other medications you're on, because so many things can affect that thyroid function. And just diagnosing by pathology or, and not including everything else in that picture, not looking at but how that person presents in front of us. They can get misdiagnosed. And I honestly see so many people going on medication when they don't actually have to.
I mean, and that is in one part frustrating, but two parts hopefully a sense of hope where it's like, hey, there can be plenty other things that we can do for our thyroid that may actually mean that I don't have to take that step in management, which, as you said, it's got a place. Medications have their place, but when it's not looking at the drivers, and we talk about there's in all parts of health, gut, we're looking at the root causes, like it is every part of the body. We're thinking of bigger drivers, root causes for why the certain issue is occurring in your body. So while you've mentioned about 50 different thyroid issues that we can have, can you give, I guess, some of the underlying causes or risk factors that can contribute to thyroid dysfunction?
Yeah, sure. So I guess at the top of the list is, genetics.
Mm-hmm.
So we've all got a genetic predisposition. So we look towards, your family history. So do you have people with a thyroid condition or an autoimmune condition? The genetics for thyroid are quite varied.
Mm-hmm.
And they do, like Hashimoto's and Graves' disease, they have quite a lot of different autoimmune and inflammatory conditions. And sort of thyroid predisposition genes that kind of combine together. It's no one gene that you've got this, you're going to get a thyroid condition. So it's a combination.
Yep.
We know that, women are 7 to 10 times more likely to have a thyroid condition than a male. So the majority of my clinic and online and face-to-face is filled with women mostly. I do still see men with hypo-Hashis. I still see men with Graves' disease, but the majority is women, and that is because, of that X chromosome, but it's also because of our being a woman. Number one, we are generally the multitaskers. We're usually busy. We're looking after kids. We're working. We're shopping. It's a bit stereotyped, but generally we are. We also put a plethora of toxic chemicals on our body every day. If you think about my partner, he gets up, goes to the toilet, grabs his breakfast and his lunch and walks out the door.
Yes.
He doesn't even deodorant. Yep. Women get up and they put deodorant on, they wash their hair, conditioner, mask, put how many different toxic makeups on their face and lipstick and rouge and body lotions and nail polish. That's a big toxicity in
Yep.
our, not only in our environment, but also, our personal care products, but in the environment. So the water we drink, the food we eat. So toxicity, but also just getting back to women, the biggest one, why women are more prone to thyroid condition, is our hormonal fluctuations throughout our lifetime. So our pubescent event is much more dramatic than, say, a male pubescent event. Then we go through our reproductive life. We have a menstrual cycle. The thyroid has to work hard in every hormonal event. Pregnancy is it's a stress test for our thyroid, postpartum, and then perimenopause and menopause. And if you have a strong family history, so like mum, aunties, grandma all had a thyroid condition, and you have not been diagnosed with one or have had any issues with your thyroid, perimenopause is a really big time when that may happen. So, perimenopause is considered almost like physiologically the same as at your puberty.
Yep.
And, you're a bit older, you've got more toxins in your body, you're probably doing, a lot more stress things, you've got children, dealing with aging parents, all of the things. So it combines to a big. So women are definitely more at risk of developing a condition. Thyroid condition. The number one driver, though, so we've got genetics, being a woman, is autoimmunity.
Yes.
As I touched on before. So Hashimoto's, when your immune system starts making antibodies, the TPO, thyroperoxidase antibodies against your thyroid tissue, over time that causes inflammation and follicular damage. So your thyroid will struggle to produce thyroid hormones, causing hypothyroidism. And it's the same as Graves being the biggest driver for hyper. So in Graves, we produce a different antibody, TRAB or TSH stimulating immunoglobulin antibody. And that one actually attacks the TSH receptor, causing all your little follicular cells to overproduce thyroid hormones, causing hyperthyroid hormones. So autoimmunity is a big driver of our thyroid.
Yeah, no, I was going to say, what is it?
Yes, well, that's it. It's like, okay, so you've got Hashimoto's, you've got Graves, but what flipped on? Well, okay, genetics, being a female, those environmental toxins we looked at, so fluoride, halogens, chloride, all of those things that chlorine, heavy metals. It could be a viral infection. It could be stress is huge. Poor gut health is huge as well, as we know. Nutrient deficiencies and a hormonal shift as well. So there's a big sort of what we call a storm, a perfect storm that trips on your immune system with a combination of all those things we just talked about. And everyone is different. So it's really important to find your unique drivers and triggers, because that is key to your recovery. That's key to what we'll be working on in your treatment.
Yep.
And, and just going back to symptoms as well, it's that and I mean, you touched on it really lovely, Rachel, is that no two people will present with the same symptoms. So we can have exactly the same pathology. We can both have Hashimoto's. We can both have exactly the same pathology, but the way that you experience a loss of thyroid hormones in your body, where your receptors are not working that well, or your genetics, applicable to those receptors, will be totally different to mine.
Yeah.
So everyone is different in how they present symptomatically, but they're the main sort of drivers. It's this, usually it's autoimmunity, but we can have hypo and hyper without having, but it's not actually common. Probably 95% of all hypo is Hashimoto's, and 95% of all hyper is Graves' disease.
So that also really makes sense when we were talking about how just taking a medication for the thyroid isn't quite cutting it, is because it's actually, when you peel that layer off and you're looking that bit deeper, it is an issue of the immune system. And then the question is, what's caused the immune issue? Like it is the question this is what goes through my head, and I get patients to kind of do this, not expecting them to find an answer, but it is the question of why. Like you do need to keep asking that question why to actually get to a place where there's meaningful change, or where I guess there's meaningful issues, big issues that need to, I guess, have change happen to them for there to be, the flow and effects that we want. Just kind of working at that top tier level, nothing much is going to happen. And I guess bringing it, to a little bit more gut connection. You mentioned gut. So how is it that, and that, because, we've spoken to Brad Leach, and he, was talking about the microbiome and autoimmunity, which that is a big link when we talk about thyroid health. So does the thyroid affect the gut affect the thyroid? I see it in my clinic that it can be this horrendous vicious cycle where they're kind of feeding each other. So tell me, how are those two big organs linked to each other.
Yeah, that's fair. I think it's probably one of the, the main, apart from like, yeah, cortisol and stress,
Yes.
like, yeah, and poor sleep that goes into it, the gut is definitely a big sort of triggering factor for a thyroid condition.
Mm.
So we know that, we need a healthy gut for conversion. So when the thyroid hormones are released out into the bloodstream,
Yep.
they mostly T4, they travel around in the body and they need to be converted. So 20% happens in peripheral tissues, 60% happens in the liver. So the liver is a really important one for
Yep.
converting that. 20% happens in the gut. So we need a healthy gut for that to happen. We know that like a gut is, healthy gut function. When we eat food, we absorb the nutrients from it, or when we take supplements. So if your gut is not working well, if you have low HCl, which often happens in a thyroid, hypothyroidism, we often see poor digestive function.
Yep.
You think about hypothyroidism, everything slows down. So your digestion slows down, your ability to break down food slows down. We can often see one of the common symptoms, but not for everyone, is constipation in
Yes.
hypothyroidism, but not always, more
True.
commonly than not. Actually, I see dysbiosis and loose stools, and that's a common feature in Hashimoto's as well. We see this
Mm.
high bacterial diversity in the research in Hashimoto's patients. So we see overgrowth of different bacteria in this dysbiosis.
Mm.
So that can affect your, cause intestinal permeability, which drives autoimmunity, which affects the absorption of all our essential nutrients that we need for thyroid function, like our selenium and our iron and our zinc and all of our nutrients pretty much. So we often see thyroid conditions and gut conditions go hand in hand, like I touched on constipation, but we can
Yep.
often see SIBO or small intestinal bacterial overgrowth, celiac disease, and other gut autoimmune condition is really common in both our Hashimoto's and Graves patients as well.
Mm.
So there is this big bidirectional relationship between the gut and the thyroid conditions. In Graves and hyper, sometimes we see loose stools that are speeding up because those
Yes.
excess thyroid hormones can cause that as well.
Yeah, I mean, everything that you've said, I'm like nodding away, saying like, yep, yep, yep. And this is again where, if you go to Tara or you go to someone talking about the thyroid and they're like, I really need to check out your gut though. Like, it's not because they're trying to divert the conversation to this random place. They're like, this is where there could be
Yeah.
a lot of information that we need, especially if there's that autoimmune picture. What you
Yes.
also mentioned, which I think I say this every podcast, and I can't see myself not saying it, is when you mention stress,
Mm.
cortisol.
Yeah.
Our nervous system is also like the number one driver that is getting like mentioned in every state of health issue that we're talking about. The
Mm.
gut clearly features heavily, but our nervous system is one where you could also be looking after your gut and taking
Mm.
all the thyroid nutrients needed. But if you've got this high cortisol picture, if there's that dysregulated nervous system, I personally find it's hard for patients to get the results that they want if there's that part of their life which is still, I guess, chaotic,
Yeah.
for lack of a better word.
Yeah.
So, would you agree with that
Oh,
stress?
100%. And everyone says, oh, so you're just specializing in thyroid health. Don't you get a little bit bored? And I'm like, well, when you're dealing with a thyroid condition, you've got to look at everything in the body. So I'm looking at the gut, the liver, the hormones, the stress, the
Yeah.
HPA, the hypothalamus, the pituitary. We're looking at, the liver's detoxification of nutrients. Kidney health can be affected.
Yeah.
Glucose metabolism can affect thyroid health, and there's all these bidirectional relationships with a lot of organ systems in the body and thyroid. So
Mm.
yes, sometimes, and like I said before, particularly in a subclinical or a cellular hypothyroidism, or even Hashimoto's or Graves, I'm not actually treating the thyroid, so to speak. I'm
Yes.
addressing all those drivers that are causing this problem,
Yep.
and then treating the immune system because it's immune dysfunction. It's causing it, but that's what's causing it. So we've got to treat it. So yeah, I'm still keeping a lot of my naturopathic principles going and working.
Oh, look, I'm smiling because I think the same thing. People are like, oh, just the gut. I'm like, no, yeah, like there's all these, we
Things.
can't throw out the textbooks just yet. We have to keep it all so we remember that everything
Absolutely.
is connected.
And you'd be looking, if you had things such as like SIBO, or you'd be looking at, constipation or anything, you'd be going, well, what's the thyroid doing?
Yes.
Because, all the thyroid hormones are needed to activate the gut cells in the body, the enterocytes and
Yeah,
so it's
it's all connected.
all
So I
connected.
guess like when it comes to getting a diagnosis
Mm.
of, oh, I mean, again, you've mentioned many of them, but what do we need to test? What are they telling us? Because the classic story that I hear was I went to the doctor, they tested my TSH. And first of
Mm,
all, I might need you to just to explain what the TSH actually is and what that's where it functions in the body. Got my
sure.
TSH tested, it was normal. So like
Mm.
what do we need to test to actually get proper thyroid information?
Okay, well, let's go through the tests and then we can just sort of break them down a little bit.
Yes.
All right, so my full thyroid panel would be TSH. Well, we'll go into them. So TSH, TSH is our thyroid stimulating hormone, and it's a responding hormone. It blows me away really that we're just testing this marker that really doesn't have a physiological effect in the body. So
Mm,
TSH actually comes from the pituitary gland, and it's sent down in response to sort of low or high thyroid hormones in the body. So what happens is the hypothalamus, actually it all starts in the hypothalamus. The hypothalamus, it's something called the HPT axis, hypothalamic pituitary thyroid axis. And the hypothalamus is sent a message to say, okay, yep, look, there's low thyroid hormones in the body. There's a lot going on. She's having a menstrual cycle. She's really busy this week. We need a little bit more. So
yeah.
the hypothalamus sends down TRH, or thyrotrophin releasing hormone, to the pituitary. And the pituitary releases that from those signals, it'll release as much TSH down. And TSH is just this signaling molecule. It's almost like a little whip. It just goes, okay,
Hurry
whip,
up.
whip,
Yep.
she needs some more thyroid hormones.
Yep.
So release. So the follicular cells are always making thyroid hormones and they're stored in there.
Mm,
And when in response to that signal from TSH, the thyroid hormones will be released, mostly T4, a little bit of T3,
yep.
released out into the bloodstream where they'll travel around to the cells, cross over, be converted. Now, TSH is, like I said, it doesn't have a physiological impact in the body. It can be, influenced by so many things. So stress can influence that feedback loop.
Hmm.
The time of the day that you have the test can influence that feedback loop. If what season it is, how old you are. We know that we are born with quite a high TSH. It levels out around sort of 15 to 18, but then it will slowly increase again. So postmenopausal women, it's not uncommon to have a TSH from 3.5 or even 7, and that's normal for them.
Yep.
Because as we age, the thyroid actually decreases, it atrophies and it shrinks in size, its volume decreases. So TSH is a great marker, but unfortunately in the medical system, that's what they focus on.
Yes.
And TSH is not a true representation of what is happening in your body. So yes, we want TSH. It does tell us a lot, but it's not the only thing.
Yep.
So we want TSH, and then we want T4 and T3. Now, so as I said before, the thyroid predominantly makes T4. Around 90% of all thyroid hormones will be your inactive T4,
Hmm.
and about sort of like 3 to 10% is T3. So we've got a little bit of active thyroid hormone made, but mostly T4.
Yep.
So T4 will tell us about the ability of your thyroid gland to produce thyroid hormones. So if you're not on any medication and we've tested your thyroid hormones and it's below 15, it's maybe 13, I think, well, that's a little low. Anything
Yep.
lower than that is considered, quite low. And the lower that T4 will drive up your TSH, if that makes sense.
Yes.
A TSH and T4, yeah, are very much related.
Hmm.
So TSH will be in very much response to T4. But look, I've seen many cases in clinic where I've got a very healthy T4 and TSH is low, or I've got low thyroid hormones where you would think, why? And the TSH can be low as well. So that's why you've got to really put it in everything together into perspective, because
Yep.
we can see there's always, people that don't sit in that normal. Actually, most of the patients I see do not sit in that normal feedback loop.
Yes.
Okay, so we're measuring TSH, T4, and then T3. And T3 is our active thyroid hormone. And that's the sort of shows us how well you can convert T4 to T3.
Yep.
So all of that inactive hormone, 90% of the thyroid produces T4 that's got to be converted to the active T3. And a lot of people that I see, patients, don't convert well at all. So they can have poor conversion. Another sort of reason to test T4, and I'm looking at T4 and you're taking thyroxine, is that you should have a T4, like again, 15 or above. Now, when I'm seeing someone looking at the pathology and they're, say, taking 100 micrograms of thyroxine and their T4 is only like 11 or 13 or 14, I'll be saying, well, what's going on? How are you taking that medication?
Yeah.
Are you absorbing that medication? Because if you're going to be taking thyroxine, we want to make sure that you're utilizing it and you have healthy T4 in the body. So I'm always working with my patients to go, right, let's look at when you're taking it, how you're taking it, are you leaving enough space? I can't tell you how many people are not told to take thyroxine on an empty stomach and wait at least 40 to 60 minutes and no food.
Yeah.
And so many things can affect the absorption of T4 in the body, such as iron supplements, magnesium supplements, coffee, dairy. All those things can bind onto your T4. So we've got to separate those for about 4 hours away from your thyroxine for an optimal absorption. So looking at the different parameters gives me an idea of, okay, so how is your thyroid responding? Are you converting that T3? Do you have enough T3 in your body? So that's your basics, TSH, T4, T3.
Yep.
And we want reverse T3.
Yes.
Now, reverse T3 it's not under Medicare. It's around $90 to $100, I think, to actually get it tested in most labs. But reverse T3 will tell me if, again, it really looks at that, is that T4 getting converted to T3 or is it going off to reverse T3? I normally just like all of these as a baseline when I'm first seeing that patient, because it just helps me to, like I'm putting your thyroid pieces of your puzzle together.
Yep.
And I want all those pieces. I don't want to be missing that piece. It really frustrates me. You know, when you're doing a puzzle and you can't find that last piece?
Yes.
You're like, well, where's that piece? Well, I want all your puzzle pieces, so I have the full picture. So TSH, T4, T3, reverse T3, and then thyroid antibodies. Now, that because in the medical system, what they do is that, and this is the outdated medical algorithm that hopefully one day will get changed. Interestingly, things are changing in America. I follow a lot of different practitioners, and the guidelines are actually changing in America. The way that they're testing. It's actually really exciting. So I'm hoping that will filter down to Australia at some stage. So the medical profession will just test TSH and they'll go, oh, well, maybe it's 5.7. It's a little high. Off you go. Don't worry. If you're overweight and you're stressed, just, stress less. Do some exercise.
Easy.
Yes, right? And then come back in 3 months and we'll test again. And then in 3 months' time, they'll test your T4, maybe your T3. And if your T4's low, they might decide whether you go on that thyroxine or not. So I prefer to get everything in one go because I want to rule that out. I don't want to wait 3 months till you get worse. I don't want to wait 3 months to not pick up that you have an autoimmune condition and that gets worse.
Yeah.
So I like to test antibodies and I like to test all of the antibodies. So if you have hypothyroidism, and we might think, oh, well, you look very hypo, you've got a bit of a high TSH, low thyroid hormones, let's just test your Hashimoto's antibody, so to speak. But what we know is that Hashimoto's patients can have Graves' antibodies, and Graves' patients can have Hashimoto's antibodies. So I like to look, and it's not probably within the scope of this podcast at the moment, but people can flip back and forth from Hashimoto's to Graves, and these antibodies can give me a lot of information about what exactly help me to diagnose your thyroid condition, and once we get that thyroid condition into remission or in the best place possible, where you're going to sit. So people can have Graves and have TPO antibodies and Hashimoto's antibodies. And it usually means that they've had Hashimoto's for a long time, but they've flipped into a Graves flare, right? So the antibodies that I like to test are the thyroid peroxidase TPO, and that's the main aggressor, Hashimoto's. That's the one that causes the cellular damage. Thyroglobulin antibodies, they're less significant, but they can give me clues to perhaps there's thyroid nodules there or even thyroid cancers. So if I have high thyroglobulin, I'm going to recommend get an ultrasound. And then I like to get TRAB, our TSH receptor antibodies. They are the Graves antibodies, but again, can be present in a Hashimoto's patient. So I like to get them all. And I also like to get a thyroid ultrasound with every single patient as well, particularly if you've had Hashimoto's for years. And what a thyroid ultrasound really tells me, it's vital to show me your what we call thyroid parenchyma or thyroid tissue. And if you've got it'll show me if there's thyroid nodules. It'll show me if you've had chronic Hashimoto's for many years, it'll show me the tissue damage and whether there's any chance that you would be able to produce your own thyroid hormones over time.
Yes.
So people from a thyroid ultrasound, I've discovered they've had very atrophic thyroiditis or a very fibrotic or a very shrunken up thyroid where the tissue's quite dead. So we know that person, it's almost like they've had a thyroidectomy. We know they're going to need that thyroxine and they might have conversion issues. But they might need to go on some T3 at some stage. So it's just putting it all together can show us so much information. So my main ones for that thyroid patient is TSH, T4, T3, reverse T3. TPO, thyroglobulin, and TRAB antibodies,
That's like,
and a thyroid ultrasound.
and I think that is where even if some of these tests have to be organized in a private sense, to
Mm.
have that information takes out so much of the guessing game. Like, oh my goodness, like invest
I
up
don't
front.
like to guess. When patients come,
Neither.
I
Yeah.
had a patient in my clinic the other day, and he said he was a Hashimoto's male, and he said, I forgot I left my tests at home, but my doctor said they're all fine." I said,
No, send them
no.
through.
Go get your wife to send them to us, take a photo, ring the GP. I never, ever accept that your thyroid or any of your results are fine, because I can't tell you how many times I have looked at results and gone, but your ferritin or your iron is like you're deficient. Just
Yeah.
because you're not in the red, you are so low.
Yeah.
I think, GPs, they're 15-minute consultations. They don't have time to really look through everything with a fine-tooth comb like we do, right?
Yeah.
And I want to look at everything and make sure that everything's fine, which quite often it's usually not.
Look, and I say to my patients that always get a copy of your results, like, because you never know where you are down track, where someone is going to ask for them and they're going to need that historical context. But like
Yep.
you said, just the way that they're interpreted, there's differences. And gosh, 15 minutes to go through a bunch of bloods, like there's big issues, in the fact that there's not that time there. But if there is time with another practitioner, bring
Yeah.
them over, because they are going to be able to see things that maybe were missed. And I guess that I have a question, because I've actually had a lot of patients. So like I've got raised antibodies, but my TSH and my T4 and T3 are fine. And I guess I say fine and in quotation marks, because
Yeah.
we now understand there is a
Mm.
difference between optimal and, I guess, lab results,
Yes.
lab references. If
Yeah.
they have antibodies but normal TSH,
Mm.
T4, T3, do they have an autoimmune condition, or is their thyroid fine?
Well, I always consider any antibodies above the range, particularly TPO in Hashimoto's and your TRAB or TSI in Graves, is a positive for that condition.
Yep.
Now, we do know though that some people can have quite high TPO antibodies, and I think there's a bit of a grey space of what
Hmm.
actually, practices will ask me, patients will ask me, what is that number? But I don't think there is a number. I did read a research study the other day saying any TPO antibodies below 500 are okay. I sort of think anything below, and because we have different reference ranges for labs. So
Yes.
some can be less than 60, some are less than 35, some are less than 6. So I always say, look, below TPO antibodies below, just let's talk about TPO antibodies.
Yep.
Below 100, I would say, it's a mild case, right? But we're still going to support that immune modulation. We're still going to look at the drivers of why you have antibodies above the reference range, because they could get worse. Now,
Yes.
we do know there is a percentage of people, and I can't quite remember the actual percentage from the research, but there's a percentage of people that will have high antibodies, perhaps even above 500, that may never actually cause hypothyroidism.
Mm.
Okay, so there are, and I think that comes down to your genetics.
Yep.
That comes down to your level of health, your level of inflammation, and I also just the clinical insight of mine is quite optimal vitamin D levels, because I think D is that immune modulator. So I think I have seen many Hashimoto's that come to me. Look at my antibodies; they're in the thousands, but their thyroid function looks pretty good, and good in my standards. So
Yes.
there is that percentage of people that may never those TPO antibodies are kept, they're
Yep.
there, but they're not doing major damage. But I'll always look at the ultrasound to make sure that
Yep.
they do. The other thing is that, okay, you could just be in a first stage I call it like a first stage of Hashimoto. So there are stages of any autoimmune condition. And if we leave that, if we don't come in and again support those drivers and triggers of why your immune system's producing those antibodies, perhaps next week, next month, next year, 5 years, that could start to cause that
Yeah.
issue. And we also know that that immune system is making these antibodies, right? And we know that, and so you have Hashimoto's, you have an autoimmune condition. We know once you have one autoimmune condition, you are at risk of developing another and another.
Yep.
So I would still, okay, great. We don't have to, your thyroid's protected. You're obviously doing, whether it's genetics or inflammation or vitamin D or whatever
Mm.
you're doing. But I would still come in and treat them exactly the
Yeah.
same from an immune modulatory perspective, and whether that's the gut, the diet, or all of the hormones, all of the above.
Yep.
Yeah. So that's the
I
way I kind of look at it.
look, and I think for anyone that is looking at that, looking at someone in a holistic sense, but also like more about health optimization than fixing a pathology, we're going to be thinking
Oh,
still a reason. Let's not wait until you're coming back to me saying my TSH is off the like, let's actually just like be a bit proactive about it. And hopefully the sooner we step in, I say that the easier it is to manage.
yes,
Hopefully
I
that's the
agree.
case. Now, you mentioned a couple of things around nutrients, and I definitely want to premise this saying this isn't prescriptive, because I actually remember I was on placement with a naturopath, and she had a patient come into the room who had prescribed themselves iodine, and they gave themselves hyperthyroidism because they'd overdosed on iodine. So
Mhm.
I just want to say, like, this isn't permission to go out and get the next thyroid supplement on the shelf, but what are some key nutrients that we see involved in good thyroid health?
Yeah. And going back to that testing as well, that's my thyroid puzzle, but I
Mm,
also look
mm,
at full blood count. I look at liver function.
yes.
I look at glucose fasting. I look at CRP and inflammatory markers. So I'm looking at all those other metabolic markers alongside thyroid nutrients. So I guess the number one is selenium. Let's talk selenium. I think of selenium as that thyroid hero nutrient. It just has so many functions. It can reduce antibodies. It reduces that inflammation and oxidative stress. It's part of that thyroid hormone production.
Mm,
It's important in that conversion and cellular uptake. So for me, it is that one. It is safe to use in pretty much all thyroid conditions, no matter what you are presenting with.
mm,
Unfortunately, I don't test selenium anymore because it has such a narrow reference range.
yeah.
So if you are even taking the RDA of selenium, if you are eating Brazil nuts, there is a good chance that you are going to be above the reference range.
Yep.
We do know that the TGA has selenium toxicity on every selenium product, and everyone freaks out about selenium. Now, I'm not going to
Yes.
give major doses here,
No.
but yeah, let's just start by saying that you should never take nutrients without testing properly and also under the guidance of a really qualified practitioner, because nutrients, any nutrient overdose, anything,
Problems. Yeah.
there can be issues in the body, just
Yeah.
as much deficiency, and iodine is definitely like that. So I don't actually test selenium, but it is one of my really, really I love giving selenium. It can make a big, big difference.
Mm,
Iron. Let's talk about iron, because iron is needed again. It's probably number two. And even though we need tyrosine and iodine to make thyroid hormones in the first step, and then selenium and zinc come on, we also need iron in all stages of thyroid hormone production. So we need iron for the production of thyroid hormones, the conversion of thyroid hormones from
mm.
T4 to T3, and cellular uptake. And we see low iron, I would probably say low iron in, oh gosh, 95% of all my hypo patients. And I think
Yeah.
that's gut. There's the role of
Yeah. I
that.
was going to be like, that's the gut in
That's
many
the gut.
cases, isn't it?
Also, inflammation. We do know
Yes.
with low thyroid hormones, we often see menstrual disorders and heavy bleeding. Again, not in everyone. So there's a bit of a cascade of events there with iron. So I'm going to test iron and make sure that you have optimal dietary intake, that it's being metabolized in your body with the saturation transferrin, and that you have ferritin levels around that 50 to 80 mark. I mean, sometimes it's really tricky to get. If you're having any sort of hair loss and
Yeah.
I want to move your ferritin to about 80, particularly if it's related to thyroid.
Yep.
But that's not always easy. It's said than done. Sometimes I have to deal with 50 is good. So selenium, iron, zinc is really important and I see low zinc in and across the board.
Yeah.
In all, and I see interesting in hyperthyroidism. I often see high iron because iron can be inflammatory.
Yeah. Yep.
That inflammation, when people have Graves or hyperthyroidism, there's a lot of inflammation. They
Yes.
can have raised liver enzymes, they can have high iron, they can have high CRP. So there's lots of those high thyroid hormones really causes a big inflammatory cascade. So iron is kind of like, in both conditions worth testing.
Yep. And especially like, I'm assuming you'd also get not just the iron, but the ferritin and like
Oh,
again, the full, yeah,
and
the
iron
full,
studies, definitely want
yes,
all of the iron studies,
not just
absolutely.
ferritin, because we need
No,
all pieces of the puzzle.
need all pieces of the iron puzzle as well. Absolutely. So I'm looking at, so iron, I'm looking at selenium, I'm looking at zinc, which is another important one. And I always see low zinc
I do
again.
love zinc.
Zinc, again, it's so important for the gut, for the immune system, for white blood cell production. It's for, when we look at a thyroid autoimmune condition, we've got two sort of systems. We've got this thyroid that is so codependent. So every step of its production, conversion, metabolism requires nutritional cofactors. But if you think about when that immune system in Hashimoto's and Graves is making these antibodies, I mean, what are those antibodies made from? The immune system is actually gathering a lot of protein, nutrients, and they're just overproducing these antibodies, like going crazy.
Yeah.
So it's burning a lot of your antioxidants. It's burning a lot of your cofactor nutrients. So we often see a lot of nutritional deficiencies in our thyroid patients. So it's really important to get iron, zinc, what else today? Selenium, vitamin D for that immune regulation, B12 and magnesium important. But yeah, let's talk. I've saved the best one to last, and that is iodine. Iodine is one of those nutrients that, look, it's very controversial.
Yes.
Because I think there's no real definitive stand on it. And I think there's a lot of different ideas out there. But at the end of the day, we can't make up thyroid hormones without iodine. So iodine in every little follicular cell, iodine combines with tyrosine, tyrosine, which is an amino acid, which is the first step of thyroid hormone production, right?
Yeah.
So T4 is basically 4 molecules of atom, and T3 is 3 molecules of iodine.
Yep.
And T3 is 3 molecules of iodine. So it's an important one. It is one of the thyroid gland is one of the biggest reservoirs of iodine in the body.
Yep.
Then we look at the breast tissue, we look at the salivary glands, the skin, the nails, the hair. So it's an important one in the body as well. And particularly for women, for their reproductive organs, for their, reproductive functioning, iodine is incredibly important. Uterus and ovaries.
Do you test for iodine, and do you do like urinary iodine, or what do you do?
Yeah. So the gold standard is iodine loading, where you would take quite a high dose of iodine, and then you would capture your urine excretion from a 24-hour period. That is the gold standard, because you will excrete out. If you have enough iodine, you're going to be excreting a lot out. If you don't have enough iodine, you'll be holding it on.
Yes.
Now, there's a problem with that test. It's not that expensive, but number one, it's a big dose of iodine. We're looking at 25 milligrams now. So I wouldn't be giving that to anyone with hyper or Graves, for pregnant women, and you can't do that if you're on thyroxine. So that cuts out a lot of my patients.
Yeah.
The next one is corrected urinary iodine, and that is, your morning fasted overnight first urine sample. Sort of tells us more about your dietary intake, to be honest. It's not the best test, but it's pretty much sometimes all we've got, and that's what we go on. So, but we want it corrected. So what a corrected urinary iodine means is it's had a marker called creatinine put against the iodine, because creatinine will correct your urine for its volume. So you can imagine if you were up all night drinking a lot of water, you get up, you have that urine sample, that will dilute that sample and dilute the iodine. Creatine corrects that. Same conversely, if you've had a really busy day, you haven't drunk much water that day before, you don't drink anything overnight, and then you do that urine sample, it's going to be very concentrated, so the iodine will be high. So creatinine again corrects that sample for the volume of the urine. So it must always be corrected. So you're asking your GP, it's corrected urinary iodine. Now, so we get that sort of test, and yes, but there's a couple of contraindications for iodine, and that is very high TPO antibodies, high thyroglobulin antibodies, and I would not be giving iodine in hyper and Graves, because if you can imagine that we need lots of iodine to make thyroid hormones, in hyperthyroidism and Graves' disease, that we already have an excess. And giving iodine in that stage, it's like putting, kerosene on a fire. We don't need any more. Yeah. And normally when I'm working with a hyper Graves, I'm getting them into remission, getting those antibodies down, because iodine will flare those TSI antibodies. And then I test their iodine and slowly work to restore those levels. And most Graves patients, when they have come into a normal range, they will have low iodine, because they've just burnt through so much iodine with those high thyroid hormones. So yes, look, there are some contraindications. We need to test it, and we need to consider your personal circumstance before you take iodine. Interestingly, that patient that I saw just recently that came and said, "Oh, sorry, I left my test at home. Everything is fine." He said, "Except iodine." And so he goes, but he told me to go and buy, I'm talking like him. He went and told me to buy some iodine, and I got the strongest one I could get. And I went, oh, okay. And he has really high TPO antibodies. And I said, no, you cannot. Let's have a look at what your iodine is. Stop taking that really high dose, and we'll go from there and see what we need to do. So normally in that case, when I've got really low iodine, low thyroid hormone, so I know, when I see a low T4, that can indicate low iodine, right? When your hair is falling out and
Yep.
you have T4, low iodine. If you have very sore breasts around your period, that can also indicate low iodine.
Yep.
So if you've got all those three markers, I'm going to test your iodine. But then again, if you have high TPO antibodies, I'm probably going to do a work to try and immune modulate and decrease the inflammatory response in your body first before I
Yes.
get the iodine in. But what I will say is that if you have low iodine and high TPO antibodies, I like to work with dietary sources.
Yes. What are some of good, again, like this is not prescriptive, but like
No,
if we're
no.
talking iodine dietary sources, like what do you like your patients to start
Yeah.
consuming?
And it seems that when we supplement iodine, it can be very reactive in the body with those supplements. Because we both sort of point out here that iodine deficiency is just as bad as iodine excess.
Yeah.
And what is excess to you is it could be a very small amount
Yeah.
is causing that inflammatory response in your body. So we have to be careful. It seems that dietary sources, even herbal sources, are better tolerated in the body and absorbed better than supplemental iodine. So I think it's just a crude source. It doesn't matter what the dose, it's just I don't know,
Yeah.
it's not very biochemical to the body.
Yep.
So food sources that I like are, seafood,
Yep.
seaweed, increasing your seafood input rather. So all your fish, salmon, prawns, all of your good seafoods, making sure it's from clean, ethical sources as well. Seaweeds, adding seaweeds into your diet as well. So getting, nori and, those little seaweed.
Yep. That snack little, yeah.
Seaweed snacks,
Yep.
that's the
Yep.
one.
Yep.
Not cooking with nobu, so putting some big pieces of like seaweed into your soups, casseroles.
Yeah.
I
Good
like
time of
eggs.
year in winter to like
Yeah,
kind of have them in there.
yeah.
You don't really taste them, but they're there.
No,
Yeah.
that's right. And sprinkling those seaweed snacks over your salads are delicious. Eggs are a good source of iodine, and I do like that you can get kelp, like sea salt,
Yep.
and just use that as your salt source. So you've got little sprinkles of salt in kelp in that salt,
Mm.
and that can help to naturally raise your iodine as well. So they're probably my top sources
And
of
I
iodine.
love that because like this is where, food is medicine. Sometimes we do need to supplement because, we need to, but like there is a lot of power and there's also a difference how our body utilizes that. And I think it's great to hear that from your clinical experience that like you do see a difference. And so it is again about people taking, I guess, a bit of responsibility, but also, I guess, power back and being like, hey, I can help my body, again, pending it is the right thing to be eating and fill my diet with certain foods, whether it's more Brazil nuts or more iodine or zinc rich foods or whatever. And that's
Mm.
going to be helping me. Like, that's a cool thing versus thinking I've got to take this up for the rest of my life. I can't do anything else. Like, let's use our food to support ourselves.
Yeah. So you
Um,
could get, a
yeah.
couple 2 to 3 selenium nuts a day. You could, sprinkle some of those seaweed snacks over them, and get some organic pumpkin seeds, which are really high in zinc. Put
Mm,
some olive oil or some ghee in a fry pan, and put just your pumpkin seeds in, and sprinkle some like your kelp salt over the top with some cumin seasoning,
mm.
and just toast them lightly, and keep them in a jar. And that's a great little thyroid boost right there. You've got some zinc, you've got some iodine, you've got some selenium, and
Yeah.
then have a steak that night, and you're all good to go.
I love that. Little
Yeah.
toppers and little,
Vitamin D in the ghee, it's
tick, tick,
definitely,
tick.
yes, definitely use diet to support.
I love that. And it helps diversity of different foods, which is what we
Yeah.
talk about when it comes to the microbiome as well.
And
Um,
can I just talk about one more
of
nutrient,
course.
something called myo-inositol. And I think this one is
Yes.
our kind of our newer, not, it's been around for years, but it's something that I think is sort of my 3 top nutrients for thyroid.
Mm,
No matter what sort of thyroid condition, would be vitamin D, selenium, and myo-inositol.
yep.
So myo-inositol, around sort of 600 milligrams a day, combined with about sort of 83, 85 milligrams of selenium, micrograms rather, has been shown to reduce thyroid antibodies and improve like TSH levels. So particularly for your hypohashis, bringing in myo-inositol can decrease your TSH levels and decrease your antithyroid antibodies, and also it helps at that receptor level of getting T3 into the cell. So it's
Yeah.
got inositol has become another one of those nutrients that I'm really regularly giving to my thyroid patients, both Hashimoto's and Graves, actually.
And I think people may have heard of it in relation to blood glucose regulation, maybe PCOS
Yes.
as well. So I think this is
Mhm.
where some of our nutrients have, you know,
Also,
multiple, you know, implications. And there are probably
yeah.
going to be people out there that have PCOS or blood sugar dysregulation with
Oh,
thyroid. So you're like, you know,
yes.
two
Yeah.
birds, one, is that, no, I don't know, two
Yes.
things at once.
Yes.
That's what we're
Yeah.
trying to
Yes,
do.
that's right. And it also has, I was reading a research paper the other day, it has some influence on cognition as well. So that brain fog around for the thyroid function, which is a big top symptom there. So,
Yeah, I mean, that sounds like a really solid trio, vitamin D, selenium, and myo-inositol. Like you can kind of see exactly just from what you've explained how, where, and why they would
yeah.
be working together in a thyroid picture. Is
Yep.
there
Yep.
any, I'm sure you hear it all, but is there any myth or just false, I guess, statements or thoughts around thyroid issues that you want to be like, I just need to call BS on it?
Well, I guess that we've sort of touched on a bit
Yeah.
that, your TSH is normal
Hmm.
because, and I want to sort of bring in here something called a set point. And I
Yeah.
think, well, I guess two things here is that, and we have touched on it as well, is that everyone is going to have a different, your whatever what works in your body, your level of thyroid hormones is right for you, and
Yeah.
it's going to be different to others. So I think sometimes we do. So many of my patients will come in and look at my thyroid antibodies; they're huge, and I'm like, and we didn't touch on this, and I did one too, and it went out of my head.
Mm.
Is okay, but your thyroid function's looking good. You're metabolizing your hormones really well. You've got good T4, T3. Your conversion's great. What are your symptoms like? So we need to put, I talked about this at the
Yeah.
start, that thyroid puzzle, because I think we focus on pathology so much and we get really bogged down, like my antibodies aren't moving or this isn't happening. But it's like, well, how are you feeling?
Yeah.
Oh, well, actually, I'm sleeping better. Oh my gosh, I don't need that nap anymore. My energy's better. So I really try and focus on symptoms. That's my big improvement. When you come back to me after being a month on my treatment, if you're not 30%, have a 30% at least reduction in your symptoms, then I'm going to totally change everything.
Yeah.
I want to make sure that you are feeling better.
Yeah.
And I think this is where it comes into that individuality of how we are presenting and the response to those pathology as well. We need to move away. Yes, the pathology is one part of your thyroid puzzle.
Yeah.
There's so many other things to consider
Yeah.
and
You're
symptoms.
treating a person, not a number in the
Yeah.
end.
Yeah, that's right. So I guess, TSH, when people are saying my TSH is fine, it is normal. Well, what is a normal TSH? And everyone can actually have, due to genetics, is a normal set point. And I have actually tried to push people into a reference range box and they felt a lot worse. So some people can
Yeah.
sit at a 0.37 TSH and they are perfectly fine. Some people can sit, like I said, even a postmenopausal woman sit at a TSH of 5.7 and they are normal. That is right for them.
Mm.
As long as that they are really trying to focus on the thyroid hormones. So if
Yeah.
you come to me with a TSH, I'm going to send you straight back or get the right testing. I want to make sure that your thyroid is producing enough thyroid hormone and that you're converting it and you're getting into your cell and
Yeah.
that your symptoms are low to no. So that's going to be my focus, I guess. I guess, a lot of people are told, oh, we don't need to test antibodies. You just got to take this medication and everything's going to be fine. Well, that's another myth as well.
Like we've just kind of said how that doesn't.
That's my whole practice. That's all I do all day, every day. So, and I see results and that is just not right. And the other one, a big one, I think, is antibodies. Yeah, don't matter if TSH is normal. Well, we know that we've already talked about that. People can have high antibodies.
Mm.
Yes, your TSH can be perfectly normal, but is
Mm.
that affecting your thyroid hormones? Are there other symptoms in your body?
Yeah. I think like the fact that, people have heard it in the podcast, but just to like reiterate it at the end, like these are very commonly and widespread peddled pieces of information around the thyroid, and they're just not true. So if you're hearing that, but you've got that gut feeling that something's not right,
Mm.
it's because your gut feeling is trying to tell you something's not right. It's just you're getting advice that isn't
Yes.
really explaining what's going on. So if
And I
some
think the other one is like diet and lifestyle, is that, so many endocrinologists tell their patients, your diet, or someone's mentioned I should be going gluten-free, or someone's mentioned I should do
Mm.
this. And they say it's not going to make a change to your thyroid. Just take this medication, and that is probably the biggest myth, because at the end of the day, it's all about your diet and your lifestyle. That is how or that's how you put an autoimmune condition into remission. That's how you feel better,
Yeah.
is eating optimally, making sure your gut is absorbing those nutrients, and sleeping, joy in life, stressing less, managing your stress, all of those things. And that's what I teach in my programs, is that yes, we might have to put in some herbs and some nutrients, all of those things at the start, but at the end of the day, how to manage this autoimmune condition for the rest of your life is through your diet and your lifestyle.
And that, I think it goes for anything health, because really our health is a
Anything
product
else,
of the
absolutely.
environment that we're giving it.
Yeah.
And if there's that analogy of the fish, if fish is in dirty water, you're not going to give the fish medicine. You're going to take it out of the tank, clean the tank, put the fish back in and see, like we're going to clean the environment.
Yes.
So like there's a lot of power in saying, all right, my environment, food, stress, toxins around me, that is having a role. What can I do about that? Like, I feel like that is more empowering than saying there's nothing you can do about it.
Right.
Um,
Yeah.
so
Yeah.
if someone knows that they have a gut issue, not gut issue, thyroid issue, or is in the process of trying to, figure out if they do, like, what is your number one piece of advice to someone in this field of thyroid issue?
Yeah. I guess probably number one is find someone that can support you,
Mm,
support your thyroid journey. I guess if there's one thing, find that right person to help you and support you, and is thyroid literate, that knows the
yeah.
ins and outs, that's not just going to say, no, everything's fine. And also not that's who's not going to look at your results and go, oh, here you go, here's a thyroid formula, or here's thyroxine. That, we've got to look at all the underlying drivers and triggers and actually work out, is it actually a thyroid issue, or is your thyroid just responding to something upstream or downstream in the body? Do we
Mm,
need to switch that autoimmune system off? That immune system is just, running right. So yeah, that would probably be my biggest advice. And then just, nutrient dense diet, get rid of the processed foods, just eat really healthy,
yeah.
healthy
I, I, I mean,
foods.
I think this podcast episode has touched on all of the things that a thyroid practitioner would need to be thinking about, and seeing how things, like, it is no wonder that you need to be literate in thyroid if you're going to be getting, I guess, giving your patients actual sustainable results, because there's all these moving pieces that we're trying to work with. Which brings me to, if people want to connect with you, work with you, learn from you, how do we do that? And we will put these in the show notes as well, but how can people reach you?
Yeah, sure. Just, jump into my website, taranelson.com. If you're a patient, I have programs, or I work just one-to-one, but I do highly recommend my 12-week program. And that teaches the diet and lifestyle step. It teaches you how to manage the thyroid condition for the rest of your life. So we've got 12 weeks of modules. That's where I put my 30 years of experience as a practitioner, putting my own Hashimoto's into remission, and many other patients. That's where we'd probably start with. And practitioners the same. I have a tab of practitioner resources. And I run, training programs throughout the year. And there's my thyroid membership as well for practitioners.
Amazing. So there's lots of things that people can do if they want to kickstart, or just like dive back into their thyroid health. If they're like, my journey so far has not been with someone like you. I think there's just so many things that you offer. And I'm so grateful that you took the time out today to share a piece of your 30 years of learning in this field. It was amazing. And I'm sure people are just going to be gobsmacked with, I guess, the complexities of thyroid.
Yeah, thanks for having me.
Thanks so much, Tara. Thanks for tuning into Gutsy Talks. I hope today's episode left you feeling inspired to take the next step in your gut health journey. If you're ready to dive deeper, head over to rachellarson.com.au. There's a range of courses and resources waiting for you. If you loved this episode, I'd be so grateful if you shared it with others who might benefit from this information. And so you don't miss out on future Gutsy Talks, be sure to hit follow and leave a review. I'd love to hear your feedback. I'm Rachel Larson, and I can't wait to connect with you again for our next Gutsy Talk.